Welcome to the second part of the Sleep in You series, part of the Four Wings Balance Library. Today we will be taking a brief look at a variety of common sleep disorders. The sleep disorders that we're going to review today include night terrors, sleepwalking, chronic insomnia, obstructive sleep apnea, narcolepsy, idiopathic hypersomnia, REM sleep behavior disorder, or RBD, periodic leg movement disorder, or PLM, and restless leg syndrome, or RLS. The first sleep disorder we're going to talk about are night terrors. So night terrors are different than nightmares in that they're characterized by physical symptoms of fear, such as rapid heartbeat and sweating. So while asleep, an individual could appear inconsolable and unable to answer questions. They could sit upright in bed with their eyes open and look fearful or panicked, appearing awake. They may act upset, scared, confused, and or agitated. They could struggle or act panicky. They could scream in distress or shout. They could breathe fast with a quick heartbeat and sweat. And if awoken, they may experience feelings of terror or dread. Night terrors usually occur at the beginning of the night, and they last between 1 to 5 minutes, although they can last longer for some people, especially younger children. Once the night terror is over, the individual will return to their sleep pattern. The next day, that person may not remember what happened, or will they feel any associated fear unless they've been woken up during the episode. So why do night terrors happen? The reason behind night terrors is complex and really not fully understood, which is why more research is needed. There are some factors that have been established as triggers for night terrors in both children and some adults. So these triggers include being overtired, experiencing occasional sleep loss or chronic sleep deprivation, having increased stress from life changes or the stress of a changing sleep routine, such as sleeping in a new environment, being sick with a cold or flu, starting a new medication, or having another sleep disorder. Night terrors on their own are not an issue, aside from the potential risk of accidental injury. Adults who experience night terrors may also experience increased fear and or anxiety about having more night terrors, thereby affecting their ability to go to bed and or fall asleep. Fatigue can also develop if night terror episodes are frequent, which impact our next day functioning. People who experience night terrors can also disrupt other sleep, such as those who are new parents or their bed partners or even their roommates. Let's move on to sleepwalking. So sleepwalkers generally perform routine behaviors in a very calm manner while they're asleep. So these routine behaviors are often things that are very familiar to them. People who sleepwalk do rarely remember their episodes, and if they happen to remember them, they can only recall parts of that episode. Episodes are usually short, although some can be longer than 30 minutes. And episodes do actually occur normally early in the night during the first deep sleep stage. Sleepwalking is much more common in children, peaking around the age of 10, and only 2 to 5% of adults have been found to be affected by sleepwalking. And if so, this has generally started in their childhood. Adult onset sleepwalking is associated with medications and neurodegenerative diseases, or it's confused with REM sleep behavior disorder, which we'll talk about in a bit. There might be a genetic predisposition to sleepwalking because up to 80% of sleepwalkers do also have a family member who have reported episodes. So why does sleepwalking happen? Sleepwalking episodes are caused by a variety of factors that increase the normal amount of our deep sleep or create arousals, especially during deep sleep. So these factors include sleep deprivation, occasional sleep loss, or chronic sleep deprivation and feeling overtired, having increased stress, change in our sleep routine or an irregular sleep schedule, being sick, noisy environments, consuming alcohol during the evening or close to bedtime, exercising close to bedtime, and having another sleep disorder. So aside from the potential risk of accidental injury, sleepwalking episodes in themselves are usually benign or not very harmful. If episodes are frequent, however, you may have increased fatigue and sleepiness. Our next disorder we're going to talk about is chronic insomnia. So insomnia is the most common sleep disorder and can affect anyone at any age. However, it's been found that women are twice as likely to suffer from insomnia, and it's more frequent in the older population. At least 1 in 4 people have insomnia symptoms occasionally, and as many as 1 in 10 people suffer from insomnia chronically. So periods of acute insomnia are pretty common, as they're often a result of transitions during our lifespan. So situational insomnia isn't considered very normal. Chronic insomnia, on the other hand, is a dissatisfaction with sleep quality and quantity despite adequate opportunity and circumstances for sleep. So insomnia causes significant distress as a long-lasting 24-hour problem that impacts both night and daytime functioning. So aside from being unsatisfied with their sleep, people report one or more nocturnal night insomnia symptoms, so nighttime symptoms. These include trouble falling asleep at bedtime. So this is called initial insomnia or sleep onset insomnia, and is described as tossing and turning for more than 30 minutes. A few minutes to up to 20-30 minutes is considered normal to fall asleep. Another symptom is trouble staying asleep at night, which is called middle insomnia or sleep maintenance insomnia. And this is described as waking up several times during the night and or having trouble falling asleep after awakening. Waking up too early in the morning, called terminal or late insomnia, or also sleep offset insomnia, means that you're unable to go back to sleep when you've woken up before you should be awake. So occasional nocturnal symptoms do often occur when we're stressed, under pressure, grieving, or coping with a change in our lives. However, if you're in an insomnia pattern that lasts and is hard to break, you should talk to your healthcare provider to determine the cause of insomnia symptoms. For those who are diagnosed with chronic insomnia, cognitive behavioral therapy for insomnia, which is called CBTI, has been shown to have a great rate of success and long-lasting effects. Insomnia symptoms do have significant immediate and long-term consequences, which include fatigue, lower energy, lack of concentration, mood swings, and increased risk of accidents and injury. The cumulative effects of sleep deprivation and insomnia have been associated with long-term health consequences, which include an increased risk for hypertension, obesity, and depression. So because insomnia isn't fully understood, we talk about the 3 Ps model, because it appears that the brain is overreactive before going into bed, so we have a hyperarousal. So symptoms are always related to the same individual factors, which have been categorized in the 3 Ps model. So the first is predisposing factors, which are those that put the person at risk. These include our biological traits, such as our sex and age, or psychological traits, such as anxiety-prone personality. Precipitating factors are those that trigger the symptoms, and these include stressful life events, medical illness, depression, anxiety, those types of things. Perpetuating factors are those that maintain the symptoms and contribute to them being chronic. And these would include things such as poor sleep habits, which would be, spending an excessive amount of time in bed, or having poor sleep hygiene. So that would mean maybe having some screen time in bed and having napping behavior when you're already having difficulty sleeping at night. Moving on, we're going to talk about obstructive sleep apnea, or OSA. There are actually several types of sleep apnea, but the most common is obstructive sleep apnea, so we're going to be really focusing on that. So OSA occurs when an individual involuntarily stops breathing, or when their breathing becomes obstructed for several seconds while they're sleeping. When the individual does try to breathe, the air doesn't pass, or it does pass with difficulty. As you fall asleep, muscles relax throughout your body, including your upper airway muscles. So for those with OSA, these muscles end up losing too much of their muscle tone, causing their upper airway to either fully or partially collapse repeatedly while they sleep. Once the obstruction or closure of the airway occurs, there's insufficient airflow, and oxygen levels are reduced in the lungs and cells. So when that happens, an emergency signal is triggered to restore oxygen levels quickly, leading to a reestablishment of the muscle tone and allowing those airways to open and proper breathing to start. This emergency reaction can create a brief awakening, which is called a microarousal, which most sleepers are completely unaware of. Sleepers are also generally unaware that they lack air due to their apneas. So as I mentioned, OSA is the most common type of sleep apnea, but it's also the most common respiratory sleep disorder and can affect all ages. It is a myth that only men or obese individuals suffer from OSA. However, we found that certain types of individuals may have more risk. So older age, pregnancy, having a small jaw or chin structure, or being overweight does increase the risk of suffering from sleep apnea. So OSA has both sleep or nighttime symptoms and daytime symptoms. So when we look at sleep symptoms, which are also called nocturnal symptoms, They include apneas, which again are those obstructed or interrupted breathing episodes repeatedly for several seconds. And these are rarely self-reported. You also may have somebody who snores or whistles, bed partner generally complaining or worrying about snoring or breathing interruptions, which may lead to your bed partner actually sleeping in a completely separate room, choking or gasping, short awakenings or arousals, frequent need to urinate, which is also called nocturia, night sweating, and rare symptoms include agitated sleep, nightmares, insomnia type symptoms, and bedwetting. Daytime or diurnal symptoms include excessive sleepiness, which is essentially the urge or need to sleep during the day, and it's very difficult to repress that. An unrefreshing sleep, fatigue or a lack of energy, trouble concentrating and decline in memory, morning headaches, dry mouth upon awakening, irritability and mood changes, and rare symptoms for the daytime include acid reflux, heartburn, erectile dysfunction, and or a low sex drive. So OSA often depends on a combination of contributing factors, and these include an individual's anatomy and lifestyle habits. So again, some of those risk factors include larger than average tonsils or adenoids, being overweight or obese, having a large neck circumference, having a smaller receding jaw or midface, larger than average tongue, or less muscle tone than average. Given that OSA affects our sleep quality and our oxygen input, it can have severe consequences on our daily functioning, our safety, and our health. If left undetected and untreated, some of the consequences can be reversible, such as having cognitive decline, heart disease, diabetes, stroke, or experiencing a motor vehicle accident. Most night and daytime symptoms are quickly relieved when OSA is treated properly. So if you do have a bed partner who's mentioning that your sleep is, not quite right, or you're snoring, or you're gasping, take their complaints seriously. For a diagnosis, there are a combination of subjective and objective sleep assessments done either at home or in a sleep clinic, depending on your healthcare practitioner. The most common treatments include a continuous positive airway pressure device, which is also called a CPAP machine, oral breathing devices, or other appliances such as nasal dilators or a mouth guard. May also have positional therapy, surgical treatment for airway anomalies, or weight management. So moving on, we're going to be talking about narcolepsy. So narco comes from being put to sleep, and lepsy means a seizure or attack. So there are 5 main typical symptoms of narcolepsy, which show up in diverse forms and variable intensities depending on the individual. So all people with narcolepsy will have a disabling and severe daytime sleepiness that presents as a sleep attack, and the sleep attack is an uncontrollable need for sleep, and that leads people to falling asleep during various activities. The remainder of daytime functioning is actually at a normal level of alertness. Another symptom is cataplexy, and that is experienced by all those who are affected by what's called type 1 narcolepsy. So cataplexy is a sudden loss of muscle tone while being awake, which can affect all muscles or just parts of muscles. These attacks can last from a few seconds to several minutes, and they do go away on their own. During a full cataplexy attack, a total body collapse occurs, followed by temporary paralysis while the person remains fully awake and conscious. So these attacks are brought on by strong emotions, and often they're positive ones, such as laughter or excitement. Other symptoms include sleep paralysis and hallucinations at sleep onset and or offset, so when you're falling asleep and when you're waking up. And these are most often unsettling symptoms. Sleep paralysis is essentially the temporary inability to move or speak for a few seconds to minutes while being fully conscious. And this happens without an emotional trigger. Some people also experience hallucinations, which are often visual or dream-like images. And of course, those who have narcolepsy also suffer from poor sleep quality because of their interrupted sleep. Now, narcolepsy is not a very common disorder. About 1 in 2,000 people are affected, and there has been no difference found between sexes. It's likely that narcolepsy is actually under and or misdiagnosed because health professionals really don't know a lot about this disorder, and neither does the general public. Narcolepsy is also often confused with other sleep disorders, and people who suffer from it also have to deal with social stigma because they're often perceived as lazy, they're sleep deprived, or having memory problems. Symptoms will often begin in adolescence or during mid-adulthood, but can develop at any age. And it can take as long as 10 to 15 years to get a proper diagnosis. So that's quite a long time. Narcolepsy does significantly impair one's quality of life as people are falling asleep unwillingly during activities or having cataplexy episodes. Although it is a lifelong disorder, narcolepsy doesn't generally worsen over time. And the causes of narcolepsy really aren't fully understood, so more research is needed. However, the main culprit seems to be a combination of both genetics and brain chemistry. The good news is symptoms of narcolepsy can be controlled, so it is important to talk to your healthcare provider if you're having difficulty. Symptom recognition, awareness, and sleep studies allow for that proper diagnosis and treatment. Our next sleep disorder is hypersomnia. So the main feature of hypersomnia is having excessive daytime sleepiness that is persistent despite adequate sleep duration, either at night or with your naps included. Aside from severe sleepiness, other hypersomnia-related symptoms include not feeling refreshed upon awakening. So this is also referred as being sleep drunk. So it's an extreme and prolonged difficulty to feel awake and is associated with a strong desire to go back to sleep. So with this, you may also experience disorientation, confusion, irritability, and poor coordination. Another symptom is an excessive need for sleep with unrefreshing sleep despite having adequate or long sleep time. So for example, sleeping over 9 hours in a 24-hour period is frequent, which includes your long nights where you sleep 9 or more hours, and you have long naps, which are greater than an hour in length. You may also experience a brain fog, which is where the severe sleepiness disrupts your attention. So some people also struggle with concentration and memory because of this. Others experience automatic behaviors involving very brief daytime sleep episodes while performing habitual activities such as driving. People also need to talk or move a lot to counteract the need to fall asleep. Other more non-sleep related symptoms include chronic headaches, excessive sweating, and depression. The onset of hypersomnia tends to be in adolescence or early adulthood, yet due to a lack of awareness and the presence of self-blaming and that social stigma, diagnosis often happens years later. Estimates indicate that between 0.02% and 0.1% of the population is affected, which makes this a rare condition. And there is no difference in prevalence among the different sexes. When all potential causes of severe sleepiness have been ruled out, hypersomnia is described as idiopathic. In other cases, hypersomnia can be attributed to another sleep disorder, an ongoing health condition, which is such as depression, or hormonal state changes such as pregnancy or thyroid dysfunction. Hypersomnia can also be a side effect of a drug or a treatment, or the consequence of head trauma. There is more research that is needed in this disorder. Again, the same as other disorders, symptom recognition, awareness, and sleep studies do allow for the proper diagnosis and treatment of this disorder. So moving on, we're going to talk about REM sleep behavior disorder, also called RBD. So people who have RBD have a brain defect that leads them to lack that protective locking mechanism that we have, which prevents us from moving during our REM sleep. As a result of this, they move and act out what's happening in their dreams. So this can include moving their entire body. They can be talking, laughing, walking, kicking, punching, sitting up, or getting out of bed, all while being asleep or dreaming. Exhibited behaviors are usually in line with what dreams are. So this means that behaviors are really illogical and disproportionate and often emotionally charged. Behavior often mirrors typical dream content. So behavior could be being chased, feeling aggression, feeling threatened, or sexual experiences. Vigorous or violent behavior does occur occasionally or very often, happening once or several times a night, and this depends on the individual. Behavior does usually occur in the second half of the night when our REM stages are longer. Now, RBD does affect less than 1% of the population, so it does make it a rare condition. It does predominantly affect men over the age of 50. Onset is gradual, and this disorder does worsen with age. To be diagnosed, you need to have some sleep studies, a medical exam, medication review, and a bed partner report, if applicable. So as a neurological disorder, RBD is usually treated successfully. However, it can be an early indicator of Parkinson's disease, which is a neurodegenerative disease. RBD can also occur in conjunction with other neurodegenerative diseases or disorders and other neurological disorders such as epilepsy and multiple sclerosis or other sleep disorders, and as a side effect of medications. So our next two are kind of linked together, and we'll talk about why, but we're going to talk about periodic leg limb movement disorder, or PLMD, and restless-leg syndromes or RLS. So these two disorders are actually very different, but they're often confused because they often present together and they do share some resemblances. So those resemblances include both affecting the limbs, predominantly the legs. They both can start at any age, but most often they occur after the age of 50. They both can be linked to iron and ferritin deficiencies. They both have symptoms that may disrupt sleep, and both are treated similarly. However, let's talk about both individually. So the main symptoms of PLMD are involuntary movements of the limbs during sleep, especially the legs, and this is often described as twitching, kicking, jerking, or an upward flexing of the feet. Movements are found to be repetitive and periodic. Periodic movements generally don't wake up the person, but bed partners could be disturbed. Some people have reported having difficulty falling asleep and staying asleep because of their disorder. Now, about 50% of those who have PLMD also have RLS. So the main symptoms of RLS include a restless feeling that is unpleasant and uncomfortable, but hard to describe, an irresistible urge to move the legs and potentially the arms. Voluntary movements can relieve part or all of those sensations. And of course, about 80 to 90% of those who have RLS also have PLMD. So PLMD occurs when one is falling asleep or is asleep before REM sleep occurs. RLS occurs while at rest or when falling asleep, as well as after sitting or laying down for an extended period. And it does occur more frequently in the evening or at night. Women have been found to be more affected by RLS than men, and pregnant women have also been found to be affected. PLMD and RLS are either idiopathic, which means they don't have any known cause, or they are secondary to a medical condition or related to medication or drug use. Idiopathic PLMD and RLS often do run in families. Many people will experience PLMD and RLS symptoms on an irregular basis without a major impact on their quality of life. If you experience frequent or severe symptoms, then discuss them with your healthcare practitioner so you can be properly diagnosed and treated. To learn more about sleep disorders, we do provide a list here where you can actually gain some access to some evidence-based sleep information. So Canada Sleep Campaign, which is sleeponitcanada.ca, has a wealth of information about sleep, so including sleep disorders. Canadian Sleep Society also has information on sleep disorders, including brochures that can be printed off. Wake Up Narcolepsy is specific to narcolepsy, and I include that one because we do find that narcolepsy doesn't have a lot of information out there, so it's great to see some organizations that specifically target that one. Of course, Restless Leg Syndrome Foundation is also on there, and Sleep Well Nova Scotia generally deals with insomnia. However, there's some information on there, including sleep diary, that you can grab and use if you're interested. So this is the end of part 2 of the Sleep in You series. This is a 7-part series. It's part of the 4-Wing Balance Library. So please check out the other sessions if you are interested in learning more about sleep.